All right, and we're back. So we're dedicating this to finishing up bones. I had a couple emails. Vis-a-vis the study guide, I sent it to you. Effectively, it's 90% on. Oh goodness gracious! So Anna's sick. Okay.
And what does that test?
Yeah, that's what we're discussing. So it's going to be pick a day next week. We have Monday, Wednesday, Friday.
I think Friday's best.
Maybe Wednesday. We're gonna. Anyone opposed? No, I had a second before. So therefore, it is Wednesday. Congratulations. Very good. So that was today. Don't blame you now. That's all right. Yeah, I mean, I was going to ask Dr. Hilly, but she was scooting out. I was.
Dr. Miller said that either, so genetics is either going to be Monday or Wednesday, and then biology will be either Wednesday or Friday. It was like, yeah.
Well, unless it's, let's plan on Wednesday. Tell her.
And if, let's say both tests happen on weird days, take them.
Never. In your wildest dream. Seems for, well, we don't have Hannah, so it was 6, 11, we're right. Okay.
And are you, after you post the video of the test, you
Yeah, I'm sure I will. I'm sure I will. It's just more about listening to me. All right, so let us begin. So we want to finish up. We want to dedicate this to finishing up on first fractures, and then a little bit on effectively what we classify as metabolic bone diseases, not the least of which is osteoporosis, certainly the most important, with its effect on most individuals. So on that note, let me go. Let's see. So I'll get back to the PowerPoint. Voila. So I'm hoping this works, but hopefully they worked on it. So this is kind of where we were before, if you remember. The first slide looked at what's called a comminuted fracture, and a lot of people are, again, erroneously understand when we're thinking of what I call a through and through fracture. You have one fracture line, typically you have two fragments. If it's an incomplete fracture, which we'll get to, it's a little bit different. So comminuted just means there's an additional fracture line dividing the fracture site into 3 or more pieces. And yeah, I would agree it's more common and aged and the bones are brittle. It's not that uncommon in folks who are younger, to be quite honest with you. You have to understand that it's more about the nature of the trauma. And yes, it's always going to be impacted by the physical condition of the bones. But if you have a severe enough trauma, twisting, significant force of the impact, all of these are possible. So for instance, with something like this, there's not a lot you can do. I mean, they're in fairly good positions. All you really can do is maybe you would do something like cerclage wire around that. There's so much going on there. Sometimes it's better to just let it heal, see what's left, and then, do something down the road. So, and it's hard. I don't know that those bones are that terribly osteoporotic. And again, this is much more consistent with osteoporosis. You rarely see a compression fracture, and that's the way we classify them. Are stress fractures in the same ballpark? Yeah. Okay. But stress fractures are probably much more associated with athletics and sport, whereas these kinds of fractures much more consistently found in elderly folks. And the great problem is this: when you see what happens here, inevitably, now you're compromising the integrity of the spinal column. We're going to get to that in bones, though we may or may not get anywhere near that today. When we start looking at the vertebral bodies, they're designed to basically stack in such a way with the discs in between them to be able to maintain side to side something that you'll learn about called intervertebral canals, where the nerves exit. And those nerves, this is ripe for impingement. That's a common source of it. So a lot of times it's disc related. As folks get older, yeah, it's probably more bone. And again, if it would happen to someone who's a little bit younger, then you start looking at things like, is there some compromise in the bone? Has there been a metastatic cancer? There's a famous condition called multiple myeloma, which has to do with multiple plasma cells forming and typically affects vertebral bone. So there's lots of stuff like that. And certainly a fall would lend itself into it. What happened to me was disc related. It compromised an already arthritic back, and I took a fall. Basically, a chair collapsed under me. This is about 10 years ago. And within a matter of about a month after that, I had a disc bulge and it off. So, I mean, something was going to happen, but that's just the way life is sometimes. You get to a certain age, not unusual. The next series of these are very interesting. So, excessive twisting forces to bone, and yes, it's a common sports fracture. It's called a spiral fracture, and it's characterized. If you take a look here, you can start to see that fracture line sort of going up. And obviously this is two-dimensional, but you can see a line here and you can see a line here. That's probably to some extent from the overlap that's there. My guess is because it would probably be if you looked higher up, this is distal tibia, that twisting is affecting both bones. What we would always do in this kind of an injury, we would take a picture at the knee level because normally the superior portion of the fibula, near what's called the head of the fibula, you got to look for a fracture. Because the force has to be taken up, and that's a twisting injury. Where would you see that? In an adult, I mean, that's a classic skiing type of thing where you have a ski boot and you get stuck, and all of a sudden there's a twist and a tumble, and basically that boot locks you in, more or less. So even unless it releases appropriately, a lot of times it doesn't. And then that twisting injury, there's a whole classification that our Swedish friends, and it's still, I'm sure, used today, called Lagi Hansen, a name you don't have to know. And it was based on the position of the foot, the position of the leg, and then it's almost like you studied the degree of twisting, and you could predict as to how much twist there was exactly where the fracture lines would be. So, and they had so much experience with skiing, both downhill skiing and with cross-country skiing. That's really where it's a fair amount. Friends of mine, a guy who later went on to be a surgical chair at a podiatry, so the one who's still an emeritus, who graduated with me over in Cleveland. That's now Kent State now owns that business. I mean, he studied extensively in Switzerland because they really had a lot of information on the traumatic aspects, the material science behind it, the things they used to make. The advances are constant in things like pins and plates and screws, the nature of the materials. It's fascinating. So that aspect of orthopedics fascinates a lot of people that are there. And we're not even talking yet about implant arthroplasty. I'll probably talk a little bit more about that, artificial joints, in the as we get into joint dysfunctions themselves. So that's common. Now, if you look at the bone here, again, it's hard to tell from these images. Again, I don't think it's that terribly osteoporotic. That's just the quality of the film that's there. Now, the big question is, this is what a child's bone looks like. That's an epiphyseal plate. You can see plate here. You can make a little bit of the plate here. Now, suppose that fracture occurred in a child. And it does. What does it tell you? You see a spiral fracture of an extremity bone in a child. You work in an emergency room, and that comes in the door. Abuse. First thing you got to rule out, a word about this. Look, we see it's terrible. I could tell you stories that would just destroy you. I'll tell you. My first wife was the head nurse in the emergency room. When I met her, she was the assistant head nurse, and she became the head nurse. The other guy left, a friend of ours. And we had a case where we had a kid come in who was, quote, abused by the uncle. Every possible way. To the point, and we had a small hospital in Philadelphia. They literally kept this poor little 3-year-old girl alive by doing CPR, by doing care until a team could come from CHOP, Children's Hospital of Philadelphia, giant, like our and get her somehow there to get help. There's so much of that stuff going on. joints. You know, by the time we got home, she got a call when we got home that the child had for days like this. I mean, terrible things. Taking out metal spatulas. We saw lots of things. I'm not suggesting anything other than to be aware of it. It's not your call to make. This is something, if you're going to go into a clinical field, it's all the classes. It's not your call to make. If it meets a certain criteria, whoever is in charge is obligated to report that to the authorities. The authorities handle it. Okay? Whether it's somebody, your next door neighbor or your best friend, you can't be the one to say, oh, I know this person. They would never do it. Nobody knows. Honestly. How many things you see? We never knew he was a mass murderer next door. Crazy. It happens all the time. That's not your call. Your legal obligation. And if you're in a licensed field, you can lose your license because a week from then, that child goes picked up in another hospital that reports it. They go back in the records, say where your hospital would go with what was clearly a potential abuse that should have been reported. And now you could lose your license. Say 6,000 times, licenses are very hard to get. So it's what they do is that social services comes in. You've seen it on TV. Social services have to take custody of the child. They investigate. For the most part, the child is returned. My first wife, I used to joke about with our 3 little kids. They have broken bones. They knew us by name in the emergency room at St. Parker's down in Aspen. She goes, I think they're going to get suspicious. I said, maybe they'll keep the kids for like no such luck. Please, take them. Go ahead, we need a break. But the reality is that's what you have to worry about. Things, my kids used to do this. We'd be at the dinner table, and they'd always rock back and forth, but they hook their legs like behind, they rock back. Well, we yell and scream about it, because if they fall, there's going to be a spiral fracture. And kids do that all the time. It's like the 1, 2, 3 swing. You see with mom and dad are holding hand, 1, 2, 3 swing. That doesn't dislocate a shoulder because the pole is even. It's that one, they're grabbing the kid's trying to twist away, they don't let go. That's where you see spiral fracture in the upper extremity. And the other one would be dislocated. Unilateral. All of those red flags go over. I've seen all that stuff. Sorry. I told you, I have them now. My kids come near me. Elder abuse, please, they're hurting me. I'm that dad. I know, I'm afraid. I'd be afraid. Here we are. Epiphyseal plate fractures. When it comes to kids, this is the structural weak point, like we talked about before. That area of the growth plate, the hypertrophic zone, it begins to calcify. Boom, right there. Nothing unusual about it. That's there. A lot of the times, it's almost like they click and click back. And there's a whole way of categorizing them. If you want to do it, you don't have to know this or anything like that. But for instance, if we have, and this is the plate, a lot of times it just snaps one way and snaps back. That's called a type 1 fracture. It's a very famous classification called. It's not Harrison, it's Salter-Harris. And it's interesting because Bees, who also contributed to that, I met once. I was down in Virginia doing a program. And the other one, sometimes it'll even, you'll see the fracture fragment, and what you'll see with it is a little piece like of this. You get a little piece of the shaft will come off. That's called a type 2 fracture. When it's intact like that, whether you have a little section of the diaphysis, and the fracture runs through there, they heal relatively speaking uneventfully. They're very, very common. The big problem, because it's a growing bone, is if the fracture line goes through the cartilage. So whether it goes through the cartilage, that happens to be a type 3, and if it goes up in the shaft, we call it a type 4. And what it does is now you have the potential for irregular growth. that one side will not grow at the same rate as the other side. And that, then you really need specialist care because they may have to electively stop a plate from growing. If one side's growing too much and one's not growing enough, sometimes if you're lucky and you get it toward the end of growth, you can basically put a blocker in that growth. So there's a lot of nuances to that. Because that, and all of a sudden you get a joint that's distorted, and now there's surely going to be some type of repurpose. And sometimes you'll just get a crush injury, which is really bad. Child falls from a height, crush injury, the plate is basically destroyed. That's always very profitable. So, I mean, there's a whole subset of those. Thankfully, the most common ones are maybe similar to what you see here in the sense that you're just getting across the growth plate. And once you reposition it, I guess it depends on the location and the stability as to whether or not you'd have to put some type of metallic hardware in to hold it. You got to watch out for this area. As you'll learn, not today, but next time we're in lab, these are called the femoral condyles. You have similar condyles in the humerus. The bones are analogous, large bone, two giant condyles. That's called a supra, above, condylar fracture. And when those are displaced, that very often compromises nerve and blood vessels. Okay? And you got to be watchful of that because if it's not treated properly, all of a sudden the blood supply is not going in and they could lose arm. Little things like that. And it's the oldest story in the world. If you're going to go in a field like this, it's all about experience, experiential. You see one, you hear about it, and all of a sudden it says, oh, if we had missed that, we could have been in big trouble. Those stick in your mind. There's always potential things that could go wrong that you have to be so watchful of that are there. So that's another one of those. So there's epiphysis separates from the diaphysis along the plate, occurs where the cartilage cells are dying and calcification, like I said. That's a classic example. This is called a depressed skull fracture. Okay. And I commented a little bit on that before. The cortices are relatively strong, but then there's a fair amount of cancellous bone. It's sort of this interesting sandwich. Now, you never see one that's quite like this. I don't even know if that person would survive, but what'll happen, it'll depress, it'll break the external cortex and it impacts the internal cortex, potentially breaking it. And that can cause some significant problems. And then you have to be watchful of bleeds because the underlying area, and we'll look at that a little bit today in the skull. When you look at the interior of the skull, you have a lot of blood vessels that have created indentations on the skull bones that you will see. If they're struck like that, you get bleeding. And that's a big problem. Then you're having to worry about potentially having to be watchful for certain kinds of signs. These are classic neurological signs. I'm sure we'll talk about them in neurology. It's because with sport, we see a concussion. Now, in a child or in an adult, when you have a concussion, and I mean, they get whacked in the head, it hurts. One, you can't use strong pain medicine because it can depress respiration. So narcotic analgesics are out. This is not somebody you give morphine to. That's the strongest thing you give is Tylenol. Okay. And then, particularly with children hate it when this happens because they get clunked in sport. My boys played ice hockey. My daughter, figure skating, I told you. So, I mean, it was a walking trauma unit. And you have to basically, you do neuro checks every 15 minutes. They start to fall asleep. You have to shake them and wake them up. The sign that you look for, if there's pressure, intracranial pressure, everybody remember this, projectile vomiting. All of a sudden, they feel, I feel like, ugh, and then it's shooting across the room. Projectile vomiting. That's a major indicator of, and so it's not just whether you, let me say, not just whether you're going to be in a trauma unit doing this. I mean, it could be your kid. Yes, sir.
I used to go to Vertigo whenever I was back.
Yeah, same. It's some people, particularly once it's injured once, it takes quite a, it's like success. If you remember Sidney Crosby, in the first one of those, like 2010, he got nailed on the eye. It was here in Pittsburgh, the ice, and then he got another concussion within about 2 weeks. If it happens rapidly, Then you get these secondary concussions. The same thing would be true about that. That it takes a more substantial time to heal than we think. And maybe there was some microscopic damage. Any problems since?
I have headaches all the time.
Headaches are such a tough diagnosis. A lot of folks. I mean, I really appreciate my first wife had, which she took every medicine under the sun, nothing really. And they go through the Maxalt and the Imitrex and all, whatever they're using today. And what they are there, and we'll get to this in physiology, they're all related to serotonin receptors. And usually it's a cocktail of things that work. Hopefully, be watchful of that. They're no fun. I don't know what they can do anymore. I mean, if it gets, they have to do a workup or anything for the headaches, scans or that type of stuff.
Sent me to a chiropractor. It was like an 8-month, something like that. Something with the top of vertebrae.
Okay.
He had to like
It helped.
adjust them. And then whatever he did, I almost threw up after. I'm not gonna lie, it was so bad. But he popped something back in place, and the headaches got less.
Yeah, I mean it's interesting. I go to chiropractor for my back, and he does the next thing.
Does it work?
For me, it's helped. It's helped. A lot of people our guy's pretty good in that regard. So he helped me a lot, and I didn't have to have any surgical procedures done. But I mean, there are stories that scare me, things like that. It was my daughter used to do that in the morning when she was in high school. She was skating, you fall a lot. She'd wake up. I'd say, "Oh, you got to get ready for school. The bus is leaving, or I'll drive you guys." It's like she'd do it. I'm having an exorcist moment. I figured that head's that close to spinning. She's going to be vomiting green stuff. Famous movie? Just not ringing a bell?
Yes. What was it again?
The Exorcist.
Yes. Oh, yeah.
Thank goodness. The wonderful late Max von Sydow, one of my favorites. Love it.
I remember when we watched scary movies.
They will only.
No, they won't let me.
Heck with them. That's why the good Lord made an iPad.
It's like, what?
The good Lord made the iPad for that reason.
Or they can just.
What?
You're still scared of scary movies.
Go see if the lights on, not just the
Sometimes. You have no idea. There were so many when we were kids, and they're nothing compared to today's movies. They are nothing. They did one called House on Haunted Hill, which they've remade a couple of times back in the 50s. And people, oh my God, you won't be able to stay in the theater. Even the original Frankenstein. It was people were sleepless nights. Moving on. So that's the depressed skull fracture. This is, they are, because it's a child's bone, you can see the growth plate, you consider that the green stick. Technically, it's an incomplete fracture. And the whole idea of green stick is it tends to bend. And unfortunately, what sometimes you have to do, because the fracture is less impressive than the degree of deformity, a lot of times you have to basically complete the fracture. You have to basically take that fracture line and complete it to straighten it out and then put it in a cast or whatever you have to do to immobilize it. In an adult, that would just be classified as an incomplete fracture. But there's a certain amount of misconceptions about those things. So relatively more organic matrix, more flexible, and it's that flexibility. So you sometimes see a bow like that. It's really I've seen enough of those to tell you that they tend to all pretty well do well, as long as they're treated properly. It's not, you don't see a lot. The beautiful thing about bone, it remodels itself. So you wouldn't know there was some damage that was there. So when we talk about it, what is reduction? A reduction means you're reducing the degree of deformity. So when you talk about a closed reduction, that just means that you didn't have to any kind of surgical intervention per se. You didn't have to make a cut, visualize where the bone was, remove tissue that was in between the fracture fragments, and do anything else that had to be done. So you're just manipulating it. So by and large, it's just a lot of times it's basically redoing the moment of the fracture and snapping it back into place. That's a lot of times they're like that. They do them on the sideline all the time for dislocations in football games. Guys with their fingers pointing the wrong way, that kind of stuff. So it's manipulated back to the correct position. Open reduction, the difference with that means that you have to make some kind of an incision and expose the area, make sure there's not interposed soft tissue, reposition appropriately. Maybe there's fragments that are getting in the way. And then whether or not you use some kind of what we call it as internal fixation. So that you always see this in a hospital, ORIF, open reduction with internal fixation. Again, if it was an open fracture, you wouldn't necessarily do that, okay, because the risk of infection is too great. When you have an open fracture, a lot of times you're just going to try to find a way to get it positioned and held there without having, and almost leaving it open to fill in, because you're pretty convinced that an infection is likely to happen if you close it too soon. Because you can always close things. Not everything has to be, we call it primary intent. So when somebody gets you go to get a couple stitches, emergency room, that's being closed primarily. Secondary means you let it heal for a while, make sure there's no infection, then close it. And tertiary means you wait till the wound is healed and then you revise it in some cosmetic sense. That's there. And now there is an oddball with this that we do a lot. It is more common today. It's basically a variation of closed reduction, and we call it percutaneous pinning. Medicine's the same thing. It's like things go in style and out of style. In the early days, in the early portion, the first half of the 1900s, okay, you would see what they called external fixators. They put pins in, they put some device on the pins. Then we stopped using them. Now magically they're back. Okay. And the beauty of it is that you can basically have those in an immobilizer, take them off, do wound care. The limitation is maybe pin tract infections, which are pretty resolved with antibiotics. And so, we did a ton of these. We did something called pins and plaster. So you would basically take, like a lot of elderly people with a broken wrist. You put a pin here and a pin here, and you manipulate it, hold it, and you incorporate the plaster of Paris cast into the pins. And then eventually you let it, so it's almost reinforced it because you couldn't shift it. That's what the pins did. Now they use, again, a lot of these external fixators, and you can sort of crank them if necessary. And it's interesting, you can do them both ways. You can crank them tighter, and very famously, this is the way when someone gets a leg lengthened or a part lengthened. Let's say they had a traumatic accident. It's a very famous method called the method of Ilizarov. Don't you know that? And years ago, when in the Olympics, the Russians had the first high jumper who really crushed the 7-foot barrier, named Valery Brumel. He was a national hero in Russia, as you might imagine, the old Soviet Union days. He ended up with a terrible fracture, and the doctor there developed this method where he inserted pins and would crank them apart slowly to turn the length that he had lost in that. And he was never really, it's religious because he was a Jewish doctor in Russia and eventually had to go to Israel. And they use that method a lot with terrorist bombs, just historically, for some interest. The method of Ilizarov. There's a movie where you see that was a Jude Law movie, and Uma Thurman back in 1998, the late Alan Arkin, called Gattaca. It's actually pretty way ahead of its time movie. Really. And the guy had to, whoever the other protagonist was trying to look like Jude Law. And they all had to do with genetic programming and things like that. You only have genetically people who go into outer space. Pardon me?
You can wear those content.
Yeah.
And like shave his skin off.
All that time, you get rid of all those because they'd be constantly. Alan Arkin was the guy who was always looking for it. It's a really cool movie. I'm a fountain of useless knowledge. It's like a trap. So my wife just looks at me and goes, "You just shut up sometimes." And again, I know how to talk to her when she starts that. Yes, dear. You're right, dear. I'll shut up, dear. Shutting up now, dear. The autonomy of repair depends on the break, bone, age of the patient. Tell me about it. So they don't do as much traction as they used to, but immobilization, hey, we used to say it all the time, things heal faster than plaster. So basically immobilization is how it works. Here's how you get it's pretty straightforward. Bone is very, very vascular. So as soon as it's damaged, blood everywhere. That causes a lot of the pain because it elevates the periosteum. At that point, it takes about 3 days for this inflammatory phase. And toward the end of it, it develops this pocket of blood that starts to organize. We call it hematoma. So the oma is like a tumor of blood, but it's not a tumor, certainly. At that point, the healing commences right away. And we start to get little threads of fibrous and cartilaginous tissue that surround the fracture site, causing what we call a callus. And over time, that callus morphs typically from 3 to 6 weeks into bone really starts to form in that. And then now you have a bony callus. The term we used to give is called consolidation because now it was solid. There was enough bone. And that was really the determination when you took them out of the cast and started rehab. And then over time, could be another 2 months, could be another 6 months, the bone remodeled. And they show it to you. So the hematoma, this mass of clotted blood, and it's very, very painful initially like that. That's really where it is because it's elevated the periosteum and there's a lot of pain fibers that are in it. So that's the elevation of the periosteum. But again, a very generous blood supply. Then the capillaries begin to grow into it. Very active. Again, about those first 2 weeks, there's a tremendous amount of gobbling up, and you really see the extent of the fracture and pushing in new material. Collagen fibers, all sorts of precursor cells, matrix, and it starts mostly a spongy bone that's in there, that cancellous or spongy bone. It does the cortical bone reforms later. And so you begin to, so now we're in this fibrocartilaginous thing, but it's still not sturdy enough to be able to go without some type of protection, either externally or in a cast or something. And then over time, I'm not so sure about the timing, but early on you begin to see little hints of bone. And so really, I would say 6 to 8 weeks is about the golden time. It just depends. Children very fast. So we used to put a kid in a cast for 3 weeks with an epiphyseal plate fracture. It was magic. The hardest thing you have with kids in that was keeping them in the cast. Not going out playing basketball or, my kids are no different. And so, and now the callus formation union is, for uncomplicated fracture, 2 months, 4 months would be about right. If for the entire remodeling to occur, it could take 6 months to a year before you really wouldn't necessarily see there was any fracture site that was there. Excessive material removed, compact is laid down, new walls, mechanical straight. It gets better. Voila. And then and eventually this will remodel itself so you wouldn't know that there was necessarily something in there, without showing you a series of x-rays for it. Which brings us to the last part for today, which are the bone disorders. And really the highlight is osteoporosis. So anything that creates an irregularity between making bone and taking away bone is really all part of it. And very often there's a metabolic basis for it. Again, parathyroid hormone abnormalities, particularly excessive parathyroid hormone production, it can be a common, and there's other things that play a role in it. From osteomalacia means softening, so soft bone, versus something called rickets. Rickets we see in children, osteomalacia in adults, and they present different. We see very little rickets today, certainly in this country, and that's all because of calcium and vitamin D in rich milk. That's why we don't see it. Okay, years ago, you did. And what you would see was it was almost like the top of a trumpet in a long bone. You'd have the end, the top, but the superior epiphysis would widen. This would be the growth plate. And rather than have bone, it looked almost like a ball. So it was almost like a trumpeting head. It's something that you would classically see. So in disadvantaged areas and before the vitamin supplementation, that was not that unusual to see pre-World War II, let's say about that. I think the nutrition improved dramatically in regard to that. So vitamin D is the underlying feature. Poorly mineralized osteoid is produced, but the calcium can't get deposited because vitamin D is essential. Soft, weak bones, painful, and rickets in children. And this is what it doesn't withstand the weight. So you would see a child with bowed legs. Now understand, toes turned in or toes turned out, bowed in knees. There's certain stages of development where that's not abnormal. And I didn't do a ton with kids, but I had enough to be able to evaluate. And we look for things like congenital dislocated hips and hip dysplasia, which are more common than you think. And being able to, and there's certain things you can look at in an infant and know fairly easily with regard to that. But with kids walking, parents would get all, oh my God, little Johnny's going to be knock knee. Well, sometimes knock knee is normal for a while, or bow legged for a while. So you had to know the timings, and I used to remember them. So osteoporosis is a whole group of diseases. The misconception is that it means, oh, I have to take this. Hello? Speaking. Yes. Back for Eric. Okay. November 7th at 10. I'm sure. Yeah, it's very hard at work. So I thank you so much for getting back to me. You're very good. Bye-bye. Can you imagine your boss not paying you about $5,000 and you got to take him to magistrate's court? That's my son took the boss and they're stalling. In legal parlance, it means asking for a continuance. Don't look. We have a word for people like that. Asshole. Pardon. I tend to swear. I hope it doesn't offend everybody. I know. I'm sorry. There's always somebody who's sensitive. Sorry. Please. I'm married to a church lady. Except when she's angry, then she makes me look like. So, the whole idea of osteoporosis is this. Okay. Resorption exceeds deposit. The misconception is it's loss of the mineral substances. It's not just, people mistakenly think it's calcium. It's all a bone substance. So what happens is, even though the matrix remains somewhat normal, the overall mass declines. And so these are the areas where we see it. So again, the compression fractures, the classic hip fractures in the neck of the femur, and you see, and it's very, very, I cannot even tell you how many of those we had when I was a resident. They have fractured hips were like, it was like a sail on those things. They were just constant. So vertebral and hip fractures were very, very common. Look at the distance. It's a wonderful picture. This is what I mean by moth-eaten bone, rarefied bone, where you can just look at it. And the tragedy is it doesn't start to look like this until it's about 75% gone. That's the difficulty. Now, there's more sophisticated methods of scans today that someone my age who's concerned about how osteoporotic they are could have that looked at. There was an old DEXA scan. I don't know if they still use it, but there's a lot of modern imaging techniques that can tell you that. But this is something we see a lot in the body. It doesn't, by the time we find out there's a problem, the problem is too far gone. And you'll see this, we'll talk about it in respiratory, we'll talk about it in the heart, all of those kinds of things. That's the difficulty. That we have these wonderful built-in backup plans. It's like being on Star Trek. They got 13 backup plans for everything. Okay? And live long and prosper. Okay? And the problem is with all those backup plans, a lot of times you don't realize there's a problem until the problem is. And again, that's a difficulty. So the contrasting architecture is well pointed out. Risk factors. Ladies, listen, you're more prone to it than us guys. Most often aged postmenopausal. My first wife, very diminutive in size, dysfunctional ovaries from Stein-Leventhal polycystic ovary disease. Such a candidate for it. I mean, and I don't have a current picture. I have an older picture of her somewhere. Most often age postmenopausal women, 30% of women age 60 to 70, 70% by age 80. So she'll be 73 in January. So, and it has a lot to do with estrogen. Okay, and so, and because of the premature menopausal, which had supplements, and it's a two-edged sword because there's a problem with estrogen supplements and potentially blood clots. There were some studies about breast cancer also being perhaps impacted by this. We call, you don't want to be a management problem in medicine because it means it's tough to deal with. You like some things that are straightforward. Men are less prone because we produce, relatively speaking, for the bulk of our lives, a relatively good size amount of testosterone. Women is strictly that adrenal cortical area that produces any testosterone-like substances. So it's in that internal zone, the zone of reticular or something like that. We'll get to that too. So insufficient exercise. So what she did, I'll tell you about my first one. She would be outside in the sun all the time, in the garden. She would walk a lot. She took all the supplements, never smoked a day in her life. Okay. All those things, did not have diabetes or any type of thyroid problem. Never a drinker. All those things. It doesn't matter because sometimes it's just part of it. Those are the things at least you can control. So exposure to sunlight, why we see a lot of problems with shut-in people. You see it a lot in elderly people in the big city who want to keep their windows closed. They're very concerned in high crime areas. You see that it's tragic. It's tragic. Diet there, and a lot of times diet goes along with it. That are there, that all of those things. So I mean, these are all things to look at yourselves in your, judged by your older relatives, see what the problems are. So weight-bearing exercise, calcium and vitamin D. There are some medications. They had a fair amount of side effects. The actress Sally Field was a proponent, which we probably paid from. That was it was like induced. It basically, I think it just pulled phosphate back in from the urine, but I think there were a lot of side effects with it. So they were called bisphosphonates. I do not know if they're still used or not. I haven't treated anybody for these kinds of things in 20 years. I haven't had a prescription pad in 20 years. And lastly, Paget's. Paget, I don't know if it's the same Paget. A woman who gets diagnosed with Paget's disease of the nipple, that is a kind of breast cancer. Interestingly, it has nothing to do with bone. So we've seen that. I remember seeing it. It was an in situ, meaning my mom actually had that diagnosis through biopsy, and it was found to be cancer in situ, which means you need no aftercare whatsoever. Just taking it away was sufficient. And she went to this renowned New York metropolitan lady breast surgeon. It's crazy. But Paget's disease of the bone is sort of a combination of too much bone and not enough bone growing haphazardly. Okay, Pagetic bone is the name we give to it. Higher ratio of spongy to compact. Okay, occurs in certain areas. I've seen it in the pelvic area where we've seen this. Could it be viral? Again, these are these bisphosphonates and calcitonin might be helpful. So you can see this. You see, here's normal in the hip area. And you can see these are dense areas, and then you see areas which don't have a whole lot. So you see this sort of unusual mixture for Paget's disease. Because I can't. We operated on a lady when I was a resident, and it turned out that she was referred for this Paget's disease, but it turned out it was that one in the breast. And and so she really didn't have anything, but she had a fractured hip. But it wasn't Pagetic bone related that I can remember. That's there. It's interesting. Bone is very reflective. Tumors go to bone. Unfortunately, the two most common tumors that men and women get, bone is a predilection: breast cancer and prostate cancer. Breast cancer and bone is what we call lytic. When you get a metastasis to bone, it looks like there's a hole in the bone. Okay, where prostate cancer is blasting, it actually looks like there's an increased circular area of more bone. So a lot of times in cancers, we look to see if the impact on bone is lytic or blastic, and that gives you a hint as to where the underlying area is. There aren't a whole lot of primary bone cancer. Most of the time, cancers in the bone are secondary from other sites, those being highlights. The other one, in growing bone, there's a tragic one called osteosarcoma, which has to do in and around the growth plate area, and usually the only treatment is amputation early on. It's successfully treated if it's identified right away. And the other is called a Ewing's tumor, and I'm not familiar. I don't recall it enough to be able to tell you about it. So we didn't see. There's some other odd things that occur in bone that are there. You can see they look a little bit like a bone infection, and you probably didn't do this from micro. It's very famous, called osteomyelitis, and it means that infection has gotten into the medullary cavities where it derives its name. You typically don't see that. It usually comes from an infection from a wound, like in a diabetic wound or ulceration that's penetrated and got to bone. That's usually where it comes from. You rarely see it. I had one case of bloodborne in a child. Interesting case. So I was at the time I was practicing in rural Western PA. I had offices in Oil City and Franklin. So if you're familiar with Oil City and Franklin, I don't know why. You are? Where are you from?
My roommate is from.
Really? I'm impressed. So I practiced in that area for about 20 years. And I had a kid, and there's a lot, and it's worse now. There's a lot of poor people because all the giant industries went away. And a lady brought in her like 6-year-old, bad swollen leg, fever. And I'm like, this baby's got to go like 103. I'm concerned it's an infection. And she's like, we're broke. We have no insurance. We couldn't afford it. I got on the horn with her. Fortunately, I knew her family doctor very well. And we were able to, because we could tell she was going to be very compliant with high doses of oral antibiotics, bed care, seeing her frequently. We were able to treat what turned out to be bloodborne osteomyelitis. The reason is the growth plates. When the growth plates are open, that infection can go through the bone. When they're closed, it's a lot harder. That's why you don't see it as much. And I remember we were successfully able. I was shocked because I had this discussion. I can't take him to the hospital. There's no money at all. And I had a couple of cases. I had a case of Lyme's disease with a lady who could not. There was just, you were poorer than church mice. So there's a lot of interesting nuances. I could tell you some stories like that. All right, see you in lab. Thank you very much.